Hello, I'm Tony DeMaria from UC San Diego, and at the moment I'm in San Francisco at the TCT meeting, where there have continued to be a number of really interesting clinical trials and new developments. And what we're going to do to focus on the entire program is, in this session and the one to follow, we're going to talk about the highlights of the TCT through the entire week. And to do this with me, I have Deepak Bhatt and I have Jeff Popna, who are both professors at Harvard University, and very proud of that, obviously. So Jeff, the SAFE-PCI trial was kind of interesting, wasn't it?
It was a phenomenal trial for a number of different reasons. One is that it's a new concept. And the concept is to perform a randomized trial in the middle of a registry. So the CathPCI registry was used to identify a group of patients, women specifically, randomized to a radial or femoral access. The requisite elements within the database were used for most of the demographic variables, and then specific outcome variables were constructed that related to the trial itself. Now, unfortunately, the trial was negative. Question that was being asked was, is there a benefit with respect to bleeding events in women, radial versus femoral? But there were some trends in those patients who had diagnostic cath, and less so with those women who underwent PCI. But the structure of it, I think, was a phenomenal piece. If we could move towards randomized clinical trials that perform in structured databases, it allows us to ask many, many more scientific questions at a much reduced price. I think the total budget for the trial was $5 million.
Yeah, there's no question that this is the future, and Scandinavia is leading the way, and of course it's a lot easier for them because everyone in their country is insured by the government and all their medical records are available. But nevertheless, starting with that, they're randomizing patients as they go forward, and they've got the mechanism to rapidly do RCTs.
Well, I was just going to say, I agree with what Jeff said. This is huge for the American College of Cardiology and can serve as a template for all sorts of randomized clinical trials in the future.
Because in this particular trial, Sunu Rao, who did an exquisite job presenting it, they knew who were the radial sites, right? Because they already had a database, they knew about the clinical sites, they knew their history. So in this study, where you have to have some proficiency for radial access, they knew exactly which sites they would be able to include because those sites already demonstrated proficiency in radial catheterization. So I think it's a construct that I think is going to move forward as a clinical trial mechanism.
Yeah, and $5 million is a bargain for a clinical trial.
Yeah, $5 million is nothing as things go. Now, tell me, Deepak, what about the EUROMAX trial? That was another one that got a lot of play.
Right, it did, and it was published simultaneously in New England Journal of Medicine. So that was a trial of bivalirudin versus heparin and optional 2B3 inhibitor in patients with ST signal elevation MI destined for primary PCI. Therapy was actually started in the ambulance. But it was really meant to address the same question that Horizons asked, Horizons AMI, some years back, but whether in the contemporary era, where a lot of places are doing radial approach, for example, the bleeding benefits of bivalirudin seen in Horizons AMI would persist. And from a bottom line perspective, yes, it did. So despite the fact that half the patients in EUROMAX got a radial approach, about half got prasugrel and ticagrelor, more modern pharmacotherapy than clopidogrel, the bleeding benefit of bivalirudin still was there compared with heparin plus optional 2B3A, which meant that about half got 2B3 inhibitors in the cath lab as planned therapy, and about another quarter got it as bailout therapy. So it largely confirms the reduction in bleeding that was seen in Horizons AMI, but extends it even to maybe sites or folks who were skeptical and said, oh, well, with a radial approach, it's going to decrease bleeding, bivalirudin, it wouldn't help. It did seem to help. On the flip side, it also confirmed something that was seen in Horizons AMI, which was an increase in acute stent thrombosis in the bivalirudin arm versus the heparin plus 2B3A arm. So that, again, is a consistent finding. One difference between the two trials was that Horizons AMI did find a lower mortality with a significant p-value in favor of bivalirudin. That wasn't seen in this trial, EUROMAX.
In a very, very, very small number of events.
That's correct.
Yeah, so hypothesis generating. I guess one of the issues that we talked about before was that a lot of the bivalirudin was given in the ambulance, and that's not a system that we've used very much in the United States. And
I think it's amazing. I mean, I think it's amazing that when you have your STEMI and you're at home in Europe, that the person who comes to see you is actually diagnosing you and treating you before you even hop into the ambulance. In the meantime, it took me about 60 minutes or so by the time that they were first medical contact in the lab. It was very, very fast. And all the drugs were given up front, right, before angiography. So, look, I think that this is a very, very, it's a call to arms for U.S. healthcare systems. Now we get EKGs in the Boston area from the ambulances, and so we activate the cath lab based on the EKG reading by the ambulance attendants, the EMTs, and we activate the cath lab based on that. And so that's shortening time, but to then perform a randomized trial that starts at the EMT, I think that's pretty amazing.
It's pretty impressive, but I would say, that aspect of the trial wasn't randomized. So it wasn't randomizing whether treatment in the ambulance is better than not doing it. So I don't think we are mandated in the U.S. to switch to that sort of broad type of therapy, pharmacotherapy in the ambulance. And it'd be a little tougher in the U.S. too, because depending on the country in Europe, some of the folks that are in those ambulances are really very well trained.
Yeah, and the distances traveled are typically less. And I know from our own experience at UC San Diego, when the interventionalists used to take the first call, in about 15% of the cases, they'd come in and the patient, in fact, was not a candidate for emergent PCI.
Right.
So we will have to develop the systems not only to give the medications, but to ensure that they're given to the right people. But as you say, a call to arms, if you can get a marked reduction in adverse events by initiating therapy in the ambulance, something that we need to pursue.
Absolutely.
Yeah, so there was, of course, the COREVALVE experience. We know that TAVR is one of the hottest topics in our session yesterday on the highlights of JACC journals. Turned out that in composite, all the JACC journals published nearly 50 manuscripts on TAVR last year. Interventions had one entire focus issue, and so some new data on the COREVALVE in patients who are extreme risk for surgical procedures.
So we did, and of course, just as a bit of background, the commercially available SAPIEN device is a balloon expandable valve with a bovine pericardial leaflets, and the COREVALVE is a self-expanding nitinol frame that has porcine pericardial leaflets to it, so a little bit different in terms of its structure. And so we studied 487 patients that were deemed by 2 heart surgeons at the clinical sites and confirmed by 2 heart surgeons on the screening committee to be really at extreme risk for an operation, more harm than good. And what we found in this, very comorbid and frail and disabled population was that the 1-year all-cause mortality and major stroke rate was 25.5%, and that beat the performance goal of 43% and highly significant. We also found that there were relatively reassuring low stroke rates, 2.4% at 30 days and 4.1% at a year, and that the fear of paravalvular regurgitation was actually well treated, I think, because of how we screen the patients for the valve sizing. 11% moderate paravalvular leak at 1 month that reduced to 4.1% at 1 year. So all in all, an extreme risk population, another therapy to supplement the currently commercially available therapy with SAPIEN for these extreme risk patients.
Yeah, no question that TAVR is here to stay, certainly for the patients who have no surgical alternatives. There was another trial on yet another aortic valve prosthesis for percutaneous implantation. There's a number of them under development, so that field is going to explode.
And it's good to see that the stroke rates are, if anything, coming down.
I think part of that's patient selection. We understand who we should be doing this procedure in, but I think part of it is the reduction in the size of the catheters that we're progressively seeing over time. So putting very large sheaths and very large catheter sizes in that are being reduced. And I think that's really
the skill of the operators too, as more and more studies are done. Well, lots more to discuss. Stay with us. We'll be right back.